Right, thank you all for coming today. Um, this is our inaugural interdisciplinary Zoom recording addressing balance and falls in the oncology population. Since oncology physical rehab is a team effort, we wanted to do something to bring together the different stakeholders to share our experiences in oncology rehab. And this is the first one that we're doing. So this is a kind of a test run on everything, but this was the brainchild of uh, Chitra Srinivasan. I butchered that. So I'm sorry. I'm sorry.
You got it right.
Okay.
You're the best.
She's actually a physical therapist, a CLT, uh, oncology clinical specialist, and the director of professional growth and education for the APTA Oncology Balance and Falls SIG. Uh, as I mentioned, this Zoom session was first proposed by Chitra a few months ago, and we actually got it to go, and we fully support it. This is something very, very unique. Like I said, this oncology rehab is a team effort, so we're going to hopefully be getting physicians and more occupational therapists, speech therapists to participate. So we're very excited about this. Now, a little bit about Chitra. She's very passionate about healthcare and a lifelong learner. She's also a mentor, a teacher, and a clinician. She has over 20 years of experience in various healthcare settings in a few states across country. Her favorite areas of practice include acute orthopedics, acute women's health, and obs- obstet- obstetrics, and is very passionate about oncology. Her interest in balance and falls prevention stems from watching the profound impact of a single fall on an adult. She believes it is every clinical worker's duty to prevent falls in any setting that they work in, regardless of specialty area. She is very experienced with implementing acute joint replacement rehab programs and facility certifications, fall prevention projects in orthopedics and oncology, and QA projects related to fall preventions and safety. Her goal is to have every oncology APTA member take interest in oncology and fall prevention. Our next speaker is actually Alex Alexander, PT, DPT, geriatric clinical specialist, and she is actually the chair of the APTA Geriatrics Cognitive and Mental Health SIG. Alex graduated with her Doctor of Physical Therapy from Carroll University in Waukesha, Wisconsin in 2017. She works in the home healthcare setting uh, right outside of Nashville, Tennessee, and she's been doing this for over 6 years or 7 years. She's a big proponent for older adult and optimal healthy aging. She is passionate about hospice and works as a hospice PT at her agency. The next speaker is Casey Finn. Um, she has her bachelor's from UT Austin and master's degree from UT Dallas. She works with oncology and surgical ICU patients. She is very passionate about identifying, preventing cognitive decline in oncology patients. She has implemented a project for the management of cognitive decline in hematological oncology. Our next speaker is Bansari Thakkar, uh, and she's actually a DSC candidate, and she's also a geriatric clinical specialist. She's a seasoned clinician with experience in various settings. She's passionate about research and currently working on research in pain management. Elna Centeno, I'm sorry, is also a geriatric clinical specialist. Um, she's a therapeutic pain specialist and a Tai Chi specialist. She's a seasoned physical therapist with over 2 decades of experience in patient care, mentoring, teaching, implementing QA projects for oncology and pulmonary patients. She is a true oncology warrior as she accomplishes all while handling her personal battle against cancer for the past few years with endless motivation as she continues to inspire not just her patients, but also her colleagues, students, and friends. So on that note, I'd like to again just welcome you all here to the inaugural uh, Zoom education session. This was again, like I mentioned, the brainchild of Chitra, and we'll go ahead and start with her presentation. I can go ahead and advance the slides. Her presentation is on osseous metastatic disease. So, Chitra, you can unmute yourself, and I will advance the slides for you.
Thank you, Eric. And I also wanted to introduce you. You probably don't need much introduction. So Eric is kind of the life of the oncology balance and fall sick. I would say he motivates everybody else, and he has always been there to support all projects. And he is also the membership and communications chair. So he takes on a lot, and he's always online or helping us any time of the night or day, especially with this project as well. So thank you, Eric, for all of that work. And without you, I wouldn't be here. So I wanted to discuss about osseous metastatic disease. And what you see here on screen is like a very brief description in very simple, like a picture depicting how a tumor cell can find its way wherever it wants to. So it might start in the blood vessel, and then it invades the endothelium, and then it just goes out there, and then it's latching onto the bone, where it can either become an osteoblastic or an osteoclastic lesion. Now, honestly, tumor cells, as we know, are aggressive and they can literally invade many part of the body. But today we're going to be discussing about a very common complication and also that interferes with quality of life of cancer patients, and that is the osseous metastatic disease. Can we go to the next slide, please, Eric? Thank you. So I chose osseous metastasis over other complications related to cancer because, number one, it is the bone is one of the third most frequent site of metastasis, next only to the lung and the liver. Now, prostate and breast cancer are responsible for majority of the skeletal metastasis, I would say up to 70%. Now, in advanced metastatic disease, the relative incidence of bone mets by tumor type is about 60 to 75% in breast and 65 to 75% in prostate. And the third would be thyroid cancers, which account for about 60% of bone mets. Now, bone mets are also a major cause of morbidity, and they are characterized by various other complications related to bone mets itself, such as severe pain, impaired mobility, pathologic fractures, spinal cord compression, bone marrow aplasia, and hypercalcemia. And osseous metastatic disease is much more common than the primary bone cancer itself, surprisingly. And almost always when it's a metastasis, it's multiple and it's not usually a single lesion. And it can usually involve the axial skeleton, although sometimes it can also involve the appendicular skeleton. And like I just said, it is a major cause of morbidity, again, due to bone pain, pathologic fractures, spinal cord lesions, hypercalcemia. And we would say that the most disability is caused when a long bone fracture occurs or when there's an epidural extension of tumor into the spine. If the compression is not relieved in about 48 hours, the patient can end up with a permanent spinal cord damage as well. And pathologic fractures are known to occur in 10 to 30% of all cancer patients. Next slide, please, Eric. Now, talking about bone mets, we have three different types of lesions. It can be an osteolytic lesion, it can be a mixed lesion, or an osteoblastic lesion. Lytic, as we all know, it just means it's hollowed out. So as you can see, the very first picture on the bottom left, it's distal to the elbow, and you can see that it looks like somebody just blacked out the top, the proximal part of the elbow, and that's nothing but a lytic lesion. That's what it looks like. And the second slide, that's slide B, also shows the proximal thigh in an AP view. It also shows an impending fracture as well. It's a lytic lesion with an impending fracture, and the primary lesion here is from the colon. Now, slide C on the right, on the top to the right, is as an example of a mixed lesion where you can see both. Can you go back to the previous? Yeah, this one. Thank you, Eric. So slide C shows a pelvis, and it has an AP view of the pelvis, and it has both lytic as well as sclerotic or blastic metastasis. Now, this is from a breast cancer. And the bottom-most slide on the right shows an osteoblastic, where you don't see those black spaces, but you see those bright white, almost like sclerotic disease. So those are the blastic lesions. And, theoretically speaking, blastic lesions are less at risk of fracture than osteolytic. However, it also depends on which part of the bone, if it's in a weight-bearing bone or not. Can we go to the next slide, please? So we're going to focus on some of the common symptoms that therapists might encounter in their day-to-day, clinic. So one is bone pain. Now, why are we talking about bone pain? Because bone pain is the most common type of pain from cancer. So cancer pain, as we have, a couple of other colleagues of mine who are going to talk about cancer pain. They're very passionate about research in that area. So bone pain is the most common type of pain that can arise due to cancer. And whenever a patient with cancer has bone pain, it is highly suggestive of a bone metastasis. This is if the primary is not in the bone, and if they suddenly develop a pain, it could be suggestive of bone metastasis. Now, there are two types of, origin or causes. One is inflammatory, and the other is mechanical. So depending on the type, the treatment for the pain also will differ, okay? Now, some of the characteristics of bone pain is that it is poorly localized, so it's hard to manage. It might be worse at night after a long day's work, and it cannot be relieved with sleep or lying down, and that can be really cumbersome. It can affect the quality of life. And the intensity of pain is not directly associated with the fracture risk. However, if there is pain that is exacerbated by movement, it is an important factor in predicting impending fracture, which is important for therapists to consider. So if a patient has pain all the time, maybe they're at risk for fracture or not. That would be determined by the radiological and other tests. However, when we work with them, if the pain gets worse, that's an indicator that we have to stop. So it's important to, monitor during our sessions. Now, if a patient develops back pain and it's associated with an abnormal spinal radiograph, now this should warn us as well as the physician about a possible spinal cord compression, and it is most commonly seen in breast and lung cancer as well. It's important that we also notify or we escalate this issue to the physicians so that we can help prevent spinal cord damage. And mechanical pain could be related to the pressure or the mass effect of the tumor within the bone. And this can happen with loss of bone strength. Now this in turn can turn into activity-related pain. So they might associate PT with pain. So which is why we need to have, a good pain management team on board as well. You can go on to the next slide, get the diagnosis, okay? So coming to the diagnosis and treatment, majority of the time, the diagnosis is the responsibility of the physician. However, there are times when we might be the ones to be able to screen, clinically, like we talked about earlier, or there might be some other symptoms like, we know that the primary is elsewhere, but then the patient suddenly develops new onset pain. So then we become like the first touch and we need to refer them to the providers. So there can be clinical screening, which consists of basic, complete blood count for anemia, myelosuppression, serum calcium for hypercalcemia, etc. And then there is bone scintigraphy, there's plain radiography, there's CT scan, MRI, and also there's PET scan. So depending on what is readily available and which, where we are located, where we practice, we might not have all of this, but it's up to the physician to choose the most appropriate diagnostic tool. Now, we also have screening tools based on the radiological appearance There's a Mirrell score, spinal instability, neoplastic score. Now, this is important because when we have a patient with pathological fracture that's going to begin therapy and the patient is very enthusiastic, they want us to take him to the gym, we always reach out to the physician, and if we have access to an orthopedic oncologist, we can ask them what is the score. So based on the score, the physician can recommend, weight-bearing restrictions, or we can put together like a comprehensive treatment plan for the patient. So it's important that we are familiar with this as well, so that when we review the chart, if we see a score, we know what we should be doing, and we know how to consult appropriately. And then the treatment part of it, there's various treatments. Medical management consists of the bisphosphonates and also the monoclonal antibodies. And then there's radiotherapy. Radionuclide therapy is also considered part of radiotherapy. There can be an ablation procedure, surgery, or stereotactic radiosurgery. Can we please go to the next slide, please? Okay. I think we talked about bone pain. Can we go to the next slide, please? We can go to the next slide, Eric. Thank you. Okay, so coming the previous slide. Yeah, thank you. This one. So how do we determine what kind of activity to incorporate? So we get a patient referred to us, and the patient has bone metastasis. Now, as always, the level of physical activity is determined related to the level of fitness and the clinical condition. Now, because we said that metastatic disease also is like, kind of later on in the stage, the patient could already have a lot of side effects of treatments, and also cancer cachexia and a lot of other things going on where they can be in general deconditioned. So we do need to take that into account. So a safe outcome measure to use across the board would be the RPE, the rate of perceived exertion. So using that scale, like at an intensity of moderate. So and also monitoring the vitals, appropriately, and taking into account any new onset symptoms, and also keeping the team on board. I mean, for each and every slide, I'm going to mention the word interdisciplinary, communication and continuum of care, which is very important. And locations with pathological fractures. So we might have patients that have already had a pathological fracture, or they're at high risk of fracture, but we're not going to put them on bed rest or activity restrictions, because that's going to negatively impact their quality of life. However, if we need to work with them, we can protect those areas, and then we can exercise the rest of the body, and we can also have them adhere to the recommendation for 150 minutes of exercise at moderate intensity. And in case of stable metastatic lesions, so let's say the lesion is stable. Again, we are going to discuss this with the physician and the orthopedic oncologist. If the lesion is stable and there is no impending fracture, like in one of the x-rays that we saw in the earlier slide, there was an impending fracture. Like it's very unstable. It's going to break at any point of time. And it also depends on how much of the cortex is affected. Maybe there's more than 50% of the weight-bearing area is already affected by the lytic lesion. And then we might not be able to do anything else. However, if the lesion is pretty stable and it's been that way for a couple of months, a few years now, the pain is not getting worse, it is safe to incorporate isometric areas to that area alone, and the rest you can treat as normal, provided like we already have a report like a PET scan, and we know exactly where the lesions are, and like what activities we're going to incorporate. Next slide, please. Yes. So we talked about protecting the areas. So some of the options to protect would be using braces or splinting. It can be mechanical stabilization, similar to following surgery. Okay, like sometimes after knee surgery, the doctors incorporate an AKI. So similarly, we can be innovative. And if we have a certain area that we're worried about, we can always discuss with the orthotic team and also with the physician team and get them a brace that might be appropriate. Now, for spinal lesions, a brace is always considered because it has a lot of evidence, and it's known to protect pain as well as provide more stability. So in case of all spinal lesions, if a brace is available and if the patient tolerates it, if it's not interfering with their quality of care, we can go for it. And prophylactic stabilization is when a doctor, finds an impending fracture and they want to go ahead and fix it. As a preventive measure, they do not want it to break, so they want to fix it. And following this, we would treat them just like any other orthopedic patients. Also, just keeping in mind, if they have any other metastatic lesions, we do need to protect those areas as well. Now, the role of orthosis, facilitates a lot more exercise than someone can normally do with the bone meds, and it also helps prevent muscle atrophy, contractures, and it also minimizes the risk of thrombosis, which cancer patients are at risk to, anyway. Next slide, please, Eric. So in short, when we exercise with bone meds as therapists, we have to start with active movement rather than passive, watching for symptoms, and any loading or waiting, increase in weights, we progress slowly. We don't, rush into things. We watch for symptoms the following day, and then we can progress. And we always stop if there is an exacerbation of pain or adverse symptoms. And we need to follow the correct technique and posture, just like we would for any other exercises. And we always avoid rapid or loaded end range movements, such as rotation, flexion, or extension involving the area. Now, again, this is something that we would do anyway, but we just have to remember this. I would call it almost like watch for red flags, such as pain, new onset pain, sudden onset of fatigue, dizziness, anything that might increase fall risk, we need to keep in mind. Okay, can we go to the next slide, please? And interdisciplinary decision-making is crucial. We would need to consult the physician. We would need to consult family members sometimes. I always like to include family as part of the interdisciplinary team as well, because they're going to be offering continuum of care for patients that are going to go home. So it's very important whenever there is a facility to include a family member, we need to include them. And we have to make goals oriented to the patient and to, improve their quality of life. Now, so each patient might have a different lesion, a different type of lifestyle and different goals. So we really need to write down patient-oriented goals. And then we also need to consider the impact of loading along with the type of movement, concentric, eccentric, and plyometric, and also keep in mind the area of the bone lesions, which is why we need to have the interdisciplinary decision-making team available always. And we need to also educate and exercise caution to minimize the risk of falls, not just in our setting, but also in the post-acute or like post-rehab, wherever we work. Now, people with bone meds may be deconditioned because of treatment or higher symptom burden, so we do need to adjust parameters accordingly. But the long and short of it is we need to have them participate in exercise, and we need to also have them adhere to the activity guidelines, just like any other adult. Can we go to the next slide, please? And these are my resources, and they will be available, I think, on the website, according to Eric later on. Go to the next slide, please. And regular exercise has the potential to maintain or improve physical function and health-related quality of life in people with bone meds. So I hope that, as therapists, we will try to do the best, and we will not restrict our patients more than needed, while keeping the safety of the patients in mind and also taking the benefit of the interdisciplinary team. And I really thank everyone for attending, and thank you so much. Thank you, Rick.
Great. Thanks, Chitra. And our next speaker, see if I can find it here. Our next speaker is Alex Alexander, and you can go ahead and unmute yourself, and I will go ahead and advance the slides for you.
Can you guys hear me?
Yep.
Okay, perfect. So as Eric said, my name is Alex Alexander, and I'm going to be talking today a little bit about cognition and falls in the geriatric population. You can go ahead and advance one, Eric. So as far as cognition and falls in the geriatric population, cognition and mental health both can have a pretty great bearing on balance performance and also the risk of falls in the older adult population. Also, dementia, it is shown, affects about 2.4 to 5.5 million people every year in the United States, and its prevalence increases as you age. And those that are shown to have tested positive for mild cognitive impairment also have a 32% likelihood for developing dementia within the next 5 years. So with a lot of the baby boomers, getting to about the age of 65 here in the next couple of years, we're going to see that prevalence of dementia go up and mild cognitive impairment pretty high. Now, those individuals that are diagnosed with dementia or cognitive impairment have a 2 to 8-fold greater risk of falls compared to those who have normal cognition. Now, those that have cognitive impairment are more likely to fall more often and sustain more serious injuries and fall injuries, and also have an increased risk of mortality and are less likely to make good functional recovery just due to carryover in their cognition. Also, older adults that have cognitive impairment have usually less fear of falling than their counterparts without cognitive issues. And that is why especially with the cognitive and mental health special interest group for APTA geriatrics. We really want to emphasize the early detection is key, and the use of dual task testing or training can allow for detection of cognitive impairment and increased risk of falls, usually just due to those individuals having a decreased ability to do dual task activities. You can go ahead and advance. So I just wanted to kind of bring to light just a couple types of different cognitive diagnoses that people may see. Now, this is not an all-encompassing list. However, I just wanted to bring forward firstly, which I didn't really know a lot about this and weren't really taught a lot about this in school, but reversible dementias are often really overlooked and not really seen for what they are. So there is a little mnemonic you can use called dementia. And these reversible dementias are conditions that cause symptoms that are associated with behavioral or cognitive changes. And usually they can be resolved once the primary etiology is treated. So usually there's many causes of reversible dementia or reversible dementia that can lead to impaired neurocognitive function in the elderly population. And usually the prevalence of reversible dementia, is highly variable with a range between 8 to 40%. And this can be due to confusion. And then about 12% of the people with dementia symptoms do usually have treatable or reversible causes. So a lot of the times different medications that the patient is taking usually sometimes may cause confusion, different emotions. So usually depression, we see a high likelihood, and delirium as well is usually seen as dementia, but that can be reversed once a patient returns back home or they're put on the proper medication. Different metabolic diseases can lead to a reversible dementia symptoms. And then also screening someone and seeing how their eyes, ears, and their sleep are also could lead to symptoms that kind of mimic dementia as well. You also have normal pressure hydrocephalus, tumors, infections such as UTI, which is probably one of the most common besides the medications that can be reversed once the infection is treated. And then also atrial fibrillation or alcoholism. Now, the prevalence of the reversible dementia in those over the age of 65 is about 5%. So it's a pretty huge amount. So usually if we see somebody that has any type of cognitive diagnosis, usually when we do the screenings and the testing, usually they may screen positive, but there are some other things to look at, and also be having them sent to a neurologist to get them formally tested can kind of help us to determine if they do have a reversible dementia or if they do actually have dementia itself. Now, dementia itself is a symptom, I guess you can say, and you can think of it as an umbrella. And then hanging down from the umbrella, you have different types of dementia. So you can have Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal dementia, Parkinson's disease dementia, and then mixed dementia. And I know there's many other types as well, but these are just the most common that you see. Then you can also have, as far as cognitive diagnoses, mild cognitive impairment. So these individuals will just have more of forgetfulness, but they won't have a lot of the same symptoms that they would with actual dementia. And usually mild cognitive impairment is just a precursor to dementia. And like I said, those with the mild cognitive impairment do have a likelihood of going on to being diagnosed with dementia within the next 2 to 5 years. And then lastly, another cognitive diagnosis that some may see, especially in the acute setting, would be delirium. So again, once that delirium is treated, usually those dementia type symptoms will go away. So just for you guys to kind of know the different types of cognitive diagnoses you may see. You can go ahead and advance, Eric. So what I've put together is not an all-encompassing list, but just different tests that we can use for fall risk and cognition in those in the geriatric population. Now there's many fall risk screenings and assessments that can be completed, but the above tests that I have listed here for fall risk and for cognitive testing both have very good sensitivity. I mean, there's no specific guidelines that have been created for people with cognitive impairment related to falls prevention. So definitely more research needs to be completed. But usually due to the impaired safety awareness and their ability to dual task, usually when you see somebody that is screening high for impaired cognition, usually their fall risk screening will be pretty high. So the TUG, the 4-stage balance test, the 4-square step test, the SPPB, and the DGI 4-item and gait speed are all really good places to start. And not all of them may apply to every patient depending on what their functional level may be. However, usually gait speed is a really good determinant on their ability to see if they're good for community ambulation or what their fall risk may look like. But then some of the other ones may be a little bit lower level, but they also may have more involved that are screening different things, including perturbations, and then also their ability to sidestep. So they're all very, very good tests. One thing I will note with the cognitive testing, most of the tests that I have listed here are mostly free. The only proprietary one is the MOCA that usually some type of training will need to be completed on. But all of these tests are very good assessment measures. And there's also plenty of other screening measures that can be used before using these cognitive tests to diagnose someone with cognitive impairment. Eric, you can go ahead once more. So lastly, I just put a slide together just on a couple evidence-based interventions that we use a lot in the geriatric population to improve falls, and usually work pretty well for people that have either regular cognition or impaired cognition. So there is something called the OTAGO program. In the OTAGO program, you can get training online for it, but usually it is shown that it can reduce falls by 35 to 40% for frail older adults if it's completed properly. So just as a quick overview, the OTAGO exercises usually are taught as a home exercise program. And they can be taught also by non-physical therapists or different therapies, such as caregivers, and usually have been shown to be effective in improving physical performance measures and decreasing fall risk over a 6-month period. So usually how the OTAGO program works is it is scheduled 3 times a week as far as exercises are concerned. And then they also want 3 times a week of a walking program up to 30 minutes. And how this was originally created, and I believe it was in New Zealand, is they wanted it created over and implemented over a whole year period. Now, I know a lot of times we don't see patients over a full year period, but they can at least continue with their caregivers or on their own if it's safe and appropriate. But usually the exercises include some type of strength and balance exercises. And then, like I said, it does reduce falls by improving their executive functioning. It is also shown that Tai Chi can also improve balance in older adults and is associated with a reduction in future fall frequency. And I'm sure most of you know what Tai Chi is, but usually very slow, controlled movements focus on breathing. And a lot of older adults have this in their communities and can complete it seated or standing. But using these interventions can improve executive functioning and dual task. So there are other things that can be used as well to improve executive functioning and dual task training. There's something called the Stroop test and the go, no go test. And those have also been shown to reduce falls due to the improvement in executive functioning. Now, there are a ton of different specific interventions that can be completed to improve balance and minimize fall risk, especially dual task training, executive functioning training. But if you guys were interested, if you go to the APTA Geriatrics website and you were to go onto the main page or the cognitive and mental health SIG page, our SIG has created a cognitive and mental health toolkit. And it has good information on specific tests and screens that can be completed with those with cognitive impairment. And it is free to anybody. You guys do not have to be a member of APTA Geriatrics or of our SIG. It is free for anybody. And it's a really, really super nice in-depth handout. And then it also goes through, depending on what that patient's symptoms are, maybe what the best test would be to complete with that patient. So definitely, like I said, it's free to everyone if you guys were interested in looking into that and downloading that. And then I think you can go to the next, Eric. All right, and then here's just the next 2 pages are just my resources. But thank you guys for letting me kind of talk to you guys about cognition and falls. Like I said, I could talk about this for hours, but definitely just knowing that cognition does play a huge role in fall risk.
Okay, thanks. Get the next presentation ready here. All right. And then I think we have Casey up next. So Casey, if you want to unmute, you can go ahead and start, and I'll advance the slides for you.
All right, perfect. I'm Casey. I think I'm the only speech pathologist here on the call, but I'm going to be talking about cognitive deficits in the oncology population. You can go ahead to the next slide. So I think when we talk about cognitive changes in the oncology patient, it's important to kind of differentiate whether it's stemming from the cancer diagnosis itself, or whether it's a side effect of the treatment that they are undergoing. So this is just kind of a general overview. I tried to narrow it down to a few that I think we see most commonly, but there are definitely more. I just don't have time to talk about all of them. So just some general cancer diagnoses where cognitive deficits are a symptom. We have our primary cancers of the brain like glioblastomas, astrocytomas, but we also have, brain mets. This is typically when there's right hemisphere involvement, or the CNS lymphomas. And then some common treatments that we can see that potentially cause cognitive deficits as a symptom are our chemotherapies, CAR T-cell therapy, and then whole brain radiation. So I'll kind of go more in depth on each of these in the next slides. So you can go to the next one. So just kind of an overview on more of our actual cancer diagnoses within the brain. Our brain tumors, brain mets, and CNS lymphoma. It's important to know, what areas are they affecting and what changes do we expect to see. So when we're doing our chart reviews and we're looking at their brain imaging, we can kind of get an idea of what someone may be experiencing based off the exact location. But I always say the brain is not as black and white as we would expect it to be. It can vary very widely. Patients can present differently, even with their cancer located in the exact same spot. So it's always important to keep that in mind. But as kind of a general overview, we have our frontal lobe, parietal lobe, temporal lobe, and occipital. And then kind of some basic cognitive changes you would see. In the frontal lobe, we more expect to see planning, interpretation, organization of ideas, and our decision making. Parietal lobe is where we'll often see more object identification in our spatial relationships. Occipital lobe is obviously our vision, and then temporal lobe will see more short-term memory deficits there. I would say most commonly, the more impactful areas that we would see cognitive deficits are the frontal lobe and the temporal lobe. But again, this is that right hemisphere of the brain. If we're seeing left-sided brain involvement, that's typically more language deficits. So things like aphasia with the word finding, or just trouble understanding or expressing our language. But we can go on to the next slide. So now we'll kind of get more into the treatments and what side effects we can see from those. We'll start off with whole brain radiation. This would be used to treat cancer involvement within the brain. So whether that's primary brain cancer or treating brain metastases. And so with this one, we know that there is already brain involvement. So whether they're experiencing deficits more from that actual cancer involvement or the treatment, it could be a combination of both. From some more immediate side effects that we'd see from whole brain radiation is more acutely, you can see brain swelling. And so that can cause worsening of their original tumor symptoms. So they can become really acutely altered. You'll often, see worsening of their original symptoms. So if they were already experiencing some cognitive deficits prior to getting treatment for that, we'll just see those deficits exacerbated with the brain swelling. And then typically with worsening of those symptoms and that change in mental status, we'll often see, vision changes, unsteady gait, a multitude of different things also start presenting itself in addition. That's a more immediate side effect that we can see from whole brain radiation, but there's also research that there can be much more long-term side effects, and sometimes people don't experience any changes for a while, and then 6 months, a year, it can vary. They'll start experiencing some memory loss, and there's also research that shows that whole brain radiation can be a cause of dementia later on. We can go on to the next slide. Another common treatment that you will likely be seeing are the CAR T-cell therapies. And so this is used to treat certain types of lymphoma, multiple myeloma, and leukemias. This can lead to immune effector cell associated neurotoxicity syndrome, or ICANS for short. So in the acute setting, if you are working with these patients, you'll know that they're likely being tracked daily with a quick kind of cognitive screen at different times of the day to closely monitor their neuro status. Because they like to catch it early if they are exhibiting any sort of changes as far as cognitive changes. And so the reasoning behind this is it's hypothesized that the change in cognition is when the cytokines disrupt the blood-brain barrier. And then we can start to see confusion, drowsiness, delirium, hallucinations. They can become very, very acutely altered. And so oftentimes, you can sometimes see, patients get briefly transferred to the neuro ICU for closer monitoring and things like that, and quick intervention. Typically with this, we see a relatively quick recovery from a cognitive deficit standpoint. However, some higher level cognitive deficits can remain for a period of time. Sometimes it just takes the body a little bit extra time to completely rid of that neurotoxicity. We can go on to the next slide. Another common treatment we'll see is chemotherapy, and you'll often hear the terms chemo brain or chemo fog or brain fog. People call it different things, but it's just terms used by cancer survivors to describe their memory and thinking changes during and after their cancer treatment. So oftentimes they can feel really disorganized, they can feel confused, have difficulty concentrating, difficulty finding the right word, trouble learning new skills, and difficulty multitasking. A common one I hear is short-term memory problems. People also report taking longer to complete routine tasks, and they note changes in their verbal and visual memory as well. we can go to the next slide. So kind of bringing all of those together and talking about how that applies to the physical therapists. Looking at their deficits as a whole, a lot of times this can limit their participation in therapy. If they're having difficulty with initiation, it may look, from an outsider, it may look like they're unmotivated, or they're thinking about whether they want to do the exercises or not, whereas that's not actually the case. They're just actually having trouble with that initiation factor. They may require frequent repetition of instructions if their short-term memory is extremely impaired. They may require simplification of tasks. If we're giving them 3-step commands, we may need to bring it down to 1 and kind of work our way up from there. Cognitive deficits, just in general, can lead to prolonged hospitalizations, especially when those deficits are more acute, likely, related to more to those treatments that they're receiving, like the ICANS, or, acute changes like brain swelling from radiation. And as y'all all know, prolonged hospitalizations are not good, because patients are known to get weak with prolonged hospital stays, which can impact their mobility. So also, this can limit their carryover of information. I know y'all do a lot of education as far as restrictions and what they can work on outside of therapy, various different things, safety precautions to follow. And they just may not retain that information as well, and they might just need some extra support. So they may need, written handouts for them and their family members to reference, because oftentimes I'll go into patients' rooms, and after the medical team has rounded, and I'll say, hey, what do you remember from that conversation? And they won't have a single clue what was discussed. And so I think it's important to provide that written handout, just so they have that information to refer to later. If you're wanting them to work on things outside of just the therapy times, they may need that actual reminder to do so. So those external reminders, like setting up a notification on their phone to go off at a specific time every day, or having a journal log for them to check off when they've completed their exercises for the day. Something that's external, that doesn't put so much pressure on them to recall that information. And then, of course, using signs in the room as needed, call, don't fall, or whatever it may be, just as a kind of signal and extra reminder to them that of something that they need to do that they're maybe not as used to doing at home. And then lastly, of course, impulsivity and confusion can pose a high safety risk with mobility. They may need more repetitive and explicit instruction prior to beginning tasks, especially if some of their cognitive deficits are, impulsivity and something like that. For their safety, they'll just need that kind of constant cueing. And they also may need reminders for insight into their deficits related to mobility. A lot of times, that insight piece into not only their cognitive changes, but also any physical changes they're experiencing as well. They'll need constant insight into that, and reminders, because they're not retaining that information. You can go on to the next slide. Just like everyone's kind of touched on in their own presentations, I think interdisciplinary team is super important. If you have a patient who has cognitive deficits, you can never be afraid to ask a speech therapist if a speech consult would be beneficial, or just asking them for any tips or strategies to use during your sessions. once SLP is on board, if it's appropriate, they can help integrate work done in PT sessions and our own sessions, like memory tasks, going over transfer trainings and safety reasoning tasks and different things that will help just overall. And you can go to the next slide. I think that's it. Thank you all for having me and listening to my presentation.
Thank you. Then we've got our final presentation here. And I'm sorry if we go over, but yeah, this has been great. So we'll call up Bansari and Elna. Let me go ahead and do this.
Hello, everyone. My name is Bansari. As Eric said, I'm working on pain and doing a lot of research on it. So pain is one of the most common things that you will notice in cancer patients. Eric, if you can start with the first slide, please.
Sure. Sorry about this.
It's okay.
Yeah, as you can tell, I don't do presentations very often, so I apologize.
No, you're okay. So this is the inspiration that me and my coworker Elna got while we were working on the cancer floor and the geriatric floor. We saw a lot of patients complaining of pain, and that was another reason they were refusing therapy, and their mobility was getting declined. They were having a lot of functional decline. So me and Elna and my another coworker, we all three gathered and we did a lot of brainstorming how we can help patients with pain apart from the pharmac management. Because if you noticed, cancer patients and the geriatric patients, they take a lot of pain medication and they suffer from a lot of side effects. And this side effects can cause a lot of complication, which is another thing on the top of what the medical diagnosis is. So it's been a year that me and my coworker Elna have been researching, and we have been trying a concept known as pain neuroscience, and that's what I'm going to talk about today. So my main objective is to talk about pain and how pain affects balance, the causes of falls, and pain neuroscience education. Next slide, please. So pain is one of the most common and prevalent symptom in oncological patients. Cancer patients in general do not have enough knowledge about pain during or after cancer. So I know most of you are clinicians, and as you work with patients, you must have noticed that patients complaining, oh, I've got this diagnosis, so I know I'll have to suffer from. The other thing that hinders their mobility is the anticipation of pain. We see a lot of patients, like, they're scared of the pain or they anticipate pain, they have fear of movement, and that's what the pain neuroscience is about. So education of pain is underused in the field of oncology as per the research. So pain neuroscience education, what does it do? It enables patients to change their pain beliefs and reconceptualize the concept of pain. So pain neuroscience education is nothing. We are just trying to lay a foundation for a patient that, pain is not a threat, like, that they have to be scared of, but it can be managed. So my next slide says that how pain affects balance. So pain usually affects the somatosensory system, which impairs balance in cancer patients. It causes muscle inhibition, and balance systems share the same pathways in central nervous system. This muscle inhibition mechanism caused by pain affects balance, which leads to falls. So indirectly, pain is associated with balance and, muscle weakness, impaired mobility. Next slide, please. So which are the contributing factors for poor balance and falls in cancer patients? So if you notice, the most common symptoms that cancer patients usually are fatigue and pain. Muscle weakness is also caused by surgery, radiation, chemotherapy, prolonged hospitalization. One of the other symptoms another side effect that we all see is chemo-induced neuropathy. And chemotherapy can also lead to poor vision. So all these are the factors that leads to poor balance and falls in cancer patients. Next slide, please. So what is pain neuroeducation? So pain neuroscience is teaching people about the neurobiology and neurophysiology of their pain experience, and to teach them that it has a therapeutic effect and is not the consequence of damage, and pain can be due to the enhanced central pain rather than the structural damage. So we are just explaining patient that, sometimes the pain or hurt does not equal to harm. So sometimes patients feel that if they have more pain, they're causing more damage to themselves. So that's what pain neuroscience education is about. We are explaining patient about their pain, and we are explaining them hurt or the amount of pain that they're perceiving does not equal to tissue damage. Sometimes it's just the way our brain is perceiving or how we are anticipating pain. So an easy and receptive way for patients to be introduced to pain neuroscience education is by asking them, has anyone explained to you why you still hurt? Next slide, please. So in this slide, I will pass over the mic to Elna, and she'll be explaining more in detail about the pain neuroscience.
Hello, can you hear me okay?
Yes.
Okay, so on this slide, it says make the unknown known. So in our experience with our patients in the acute care setting, the interview portion is the most important part of our patient encounter. It makes the unknown known because sometimes we don't see in their medical chart during a review what are the hidden parts, like the yellow flags and all those kind of stuff. So ask the patient, tell me your story. Ask open-ended questions like the motivational interviewing. It's kind of like peeling the layers of the onions. Let's go beyond the barriers. Ask open-ended questions like, what do you think is going on with your back if they have back pain, or if with your hip or whatever? What do you think should be done with it? Because most of these patients have lots of experiences with other therapists. They already had rehab before, they had pain specialists before. So others are tired of physical therapy itself. And also, we can also ask, why do you think you still hurt? What would it take for you to get better? Where do you see yourself 3 years in regards to your back or in regards to your pain? So, well, asking these questions about 3 years kind of gives them hope, unless they're in a hospice care or comfort care already, but at least it gives them hope. Oh, yeah, that's right. Why am I living in pain? Kind of like that question. So I would encourage that we listen to our patients, and the most important part is make eye contact, because when these patients doesn't look at you, maybe they're not there yet, or maybe they're not ready with a pain neuroscience education. Next slide, please. Eric. Oh, back. One more. Okay, so pain neuroscience education, as what Bansari was said, is the foundation. So there are lots of research out there that shows that it really works. And we all usually share stories, metaphors, and examples. Neuroscience becomes approachable and easy to absorb. Every clinician has the capacity to teach this pain neuroscience education with practice. we usually ask the patient, has anyone explained to you how pain works? And then we explain, or there's a video that we usually show about the nervous system, that we have 45 miles of nerves, and a lot of our nerves in the human body um, acts as an alarm system. So 1 in 4 people, the alarm system doesn't come down, it becomes extra sensitive. So our goal in pain neuroscience education is to calm down the alarm system back. So next slide, please. Thank you. So for the metaphors, think of them as a technique and match it to the problem. Like for example, if you hear the patients, I have a mental fatigue, you can share about the brain meeting story. If they are in stress or overwhelmed, it usually causes pain because of the stress itself. So you can share the nerve sensor story. If they are fatigued, exhausted, or tired, you can share the lion story. But I'm not going to share these 3 stories right now. I'm going to focus on these 2 metaphors, the alarm system and the calming the nerves story, because this is a very, very popular, and this is what we usually use in our first encounter with the patients. So I'm going to share a story so it will be very, very practical. Usually if you see a patient, you're gonna ask them, okay, have somebody taught you about pain or mentioned about how pain works? If they say no, and then are you willing to learn? If they say yes, that's your go signal to tell the story. So the story goes like this about the sensitive alarm system. Like if you step in a rusted nail right now in your barefoot, would you like to know what is it? And then you wait for the patient's answer. They say, of course, I want to know. And then you're gonna ask why. And they say, yeah, you're gonna make them think instead of just telling them. So, like for example, you've got to pull the nail out, otherwise you'll get an infection. Is that right? And they say, oh yeah. And then how did you know that there's a nail at the bottom of your foot? So that will you will make them think, oh yeah. And then you're gonna ask them more, do you have eyeballs at the bottom of your foot? And they're gonna think, oh, that's right, I don't have vision in my foot. I have the sensory. And then you're gonna tell them, yeah. So you're gonna tell them, guess what, we have a 45 mile of nerves, and this is a living breathing alarm system in our body, and this is where you go through the alarm system story. And then you're going to tell them, you're going to ask them again, how many miles of nerves do we have again? So you can ask them, so they develop a recall. So you're going to know that they're really listening. So this alarm system metaphor is really, really good. You're going to tell them when life is good, our alarm system is calmed down. It's normal. But when you step on a nail, the alarm system is activated. It tips your alarm. So the message goes to your spinal cord, fires to the brain, and you're going to ask them, does that make sense? And then if you're going to wait for their answer, yeah, that makes sense. So you can connect it to the patient's pain complaint or their body part, apply it to how they feel about their pain. And then the next step is you're going to tell them, pull the nail out of the foot. The doctors provide treatment. Did you notice that when the nail was pulled out of your foot, it doesn't go away right away? The pain is still there. It lingers for a day or two. Pain lasts for a little bit. So our alarm system is sophisticated. It does not go from 10 pain level to 0 right away. It makes sure that you're okay. Our brain makes sure that we're okay. So it goes from 9 to 8, 7 to 8, 8 to 5. So this is how you plant the seed to our patients. That is not from 10 to 0, no pain at all. It's gradual. So after that, if they understand the concept of the alarm system, some of my patients will ask me, so how do I calm down my nerves? How can I calm down my alarm system? So that's a very good question. It's a very good question. So you're going to have to acknowledge that and tell them that to calm the nerves, you're gonna think that hurt does not equal harm unless they have a really new pain, they have meds, and they have new bone pain that the doctor diagnosed them to have new meds. But if they're already stabilized, like most of our patients, that they have spinal meds and they're already stabilized and they can't move because they're scared. So you can tell them that pain does not equal harm. We're here to help you. Like you tell them that before they have that pain, they have enough room for movement because the firing level of your alarm system is still up there. But when you have the pain, your nerves are extra sensitive and you have little room for activity. So this is where you're gonna introduce the gradual activity. Like you can start from bed mobility, sitting edge of the bed, sit to stand, and stuff like that. So this is really, really exciting. And I have lots of patients that really, really benefited from this, just these two metaphors. And sometimes I tell them, take a deep breath. And sometimes I ask them, do you have any meditation techniques? So I kind of encourage them to do whatever they've been doing, or relaxation techniques. Sometimes I do my Tai Chi relaxation or calming, energy conservation. And there's one more that yeah, just the breathing techniques that usually calms them down. Next slide, please. So lastly, pain neuroscience offers hope for our oncology patients, especially those that have chronic pain and those that have really been in the oncology population frequent flyers all the time. And there is hope for pain. And I usually tell them that if you don't have brain, you're not going to have pain. So when you're dead, that's when you don't have pain. So we have pain all the time. But it's the thing that is hurting today will only hurt worse tomorrow if you don't change the way you think. So I have the mnemonics that I usually kind of share to my patients. The hope dash I, hang on, pain experience improves. So this is a very rewarding experience as a physical therapist. Here, where's that? There's a chat. Oh, the Bansari, do you have anything to add?
So we have made a tip sheet for all the metaphors that we use for the patients. And if you all want, we can share it with Chitra, and maybe she can put it on the site. But yeah, the pain neuroscience, we have been using this since more than a year now, and it has really helped our patients in coping up with pain. So yeah, we love this topic. If you guys have any feedback about pain neuroscience, if you all have used it, please feel free to share it with us. We are still learning more about it, but so far we have applied most of the metaphors, and pain neuroscience has worked wonders with our cancer patients. Thank you all for listening.
On behalf of the APTA Oncology Balance and Falls Special Interest Group and the Leadership Board, which includes myself. I'm the Director of Professional Growth and Education Resources, and we have the Director of Membership and Social Media, and that's Eric Galvez. And we also have the Secretary, that's Shweta, who's here today, and we have the Chair, who is Rachel Lehack. I also want to especially thank the speakers, because all of these people, true to their dedication to oncology, at very short notice, they enthusiastically accepted our invitation, and they're selflessly sharing all their work and resources here. And the APTA Oncology Balance and Fall SIG has a list of exclusive benefits, and we do encourage all of the attendees to become members so you can benefit from those resources. So myself, I was lying on the sidelines for several years, and I was like just kind of like spying in on all the meetings. And then one of the board members reached out, and I jumped in at the opportunity, and I'm truly grateful for this opportunity to be on the board. And there's many such opportunities for members, and we have opportunities for students, those early in their career, as well as the seasoned clinician or teacher. And please do check our website and all the other resources available. Many of them are free and no membership is required even. And also do visit our Facebook and Instagram pages, which Eric routinely maintains. He is very active on those pages. And we hope to obtain CEUs for subsequent sessions. At this point, we don't know about this. We might try, but there is no guarantee on that. And again, please watch our Facebook and Insta for updates on that. And if any of you need an attendance certificate, or if you need anything in particular, we will be emailing something out by the next 10 days or so. And I know that some of us will be using this for the maintenance of specialty certification. So, there's more opportunities coming to do that as well. So just watch out. And once again, I hope you all stay warm, and thank you all for joining us. Eric, did you have any other closing comments?
You pretty much hit everything there. So yeah, the APT oncology is a fairly young SIG, so the balance and falls SIG is fairly young. So if you're interested in joining or even participating in a future Zoom call like this, we would definitely love your support. On that note, we'll go, unless Chitra or Shweta, if you have anything, we can go ahead and close it. This has been great.
I think that's it, Eric. Again, thanks to all, especially the speakers. Thank you all once again. And I also see that there's some leadership from the hospitals where most of my coworkers, I see Homer and Lynn, and I really appreciate their support, because that really means a lot to, I think it will be inspiring to other leaders from other hospitals as well. So yeah, they're also here. And literally there's about 25 to 30 participants. I thank all of them for spending their evening, and many of them have, various responsibilities. And I'm really, I feel like our SIG is honored to have all of them here. Thank you all again. Yeah.
Thank you. And we'll go ahead and end the session now, but unless anyone else has any questions or whatnot. Well, thank you for attending. Right, and I'm gonna go ahead and end this now.
Thank you, Rick.